All right. So do we have a lot of attendees right now?
Not
From
yet.
your side?
I think we can wait until people
39.
start.
So yeah, we are waiting
All right, I see.
because we just open for the participants to come.
Okay, so I think probably we can wait for like till for
5
like two
minutes or
to 5 minutes. Yeah.
Can I ask the tech support, should I leave my presentation up and then shared, or should I share it once we're in the session?
I'm not sure about the technical side. Do you have any idea from Iros?
Mayan,
Mayang, what did I didn't hear it.
Just
you
a
mean to
question.
share your presentation
Yeah, I mean,
on the screen?
correct. When should I do that, or should I do that now and leave it up?
Oh, you can leave. I think you can leave it off.
At the start of your presentation, because we have 10-minute greeting and 10-minute presentation. from
Ada
Ariel.
lagu gitu, Mayang.
Iya, Prof. Sebentar, Prof.
Okay, I think what I would do, I would just put all the agenda in the chat box so everyone can see in the panelist.
We have almost 300 participants, right, Mayang? Registered 270 or 90. So
Yes, Prof.
Registration.
Okay, I have already put the agenda in the chat box. So now I think the panelists all can see the schedule, what we are doing today.
nggak bisa di-share ininya, Maya. Nggak bisa di-share flyernya. Nah, gitu dong.
Yes, I think before we begin, we can take a picture in the panel room, Prof. Yeah. Dr. Nico. Yes, Dr. Siva, yes, we can take a picture.
Yeah.
Hi, Dr. Miriam, hi.
Okay, allow me to guide the photo session. Please hold your smartphone. 3 seconds, I will take the photo in 3, 2, 1, smile. Okay, okay. I should take another photo again. So please smile in 3, 2, 1, smile. Okay.
Thank you.
Thank you.
Shall we start? It's already 99, Maya.
Yes, please. Yes,
All right.
More than 100 people. You can proceed, please.
Okay. All right. So good morning and good afternoon, all attendees from all the countries across Asia, welcome to the 11th FARO's webinar, jointly hosted by TASRO, Thailand, and IROS and Aurora from Indonesia. My name is Sarin Kitpanit from King Chulalongkorn Memorial Hospital, Bangkok, Thailand, and I will be the moderator today. So for today's agenda, we will start with 10-minute presentation from Varian, followed by a talk from an exceptional speaker, Dr. Shankar Siva. He will talk about SBRT in oligometastases, which is an area that is being actively investigated. Afterwards, we will have about 10 to 15 minutes for answering any questions. During the webinar, all the attendees, you can drop your questions in the chat box. You can find the chat box at the bottom of your screen, or you can hit any the 3 dots sign, probably at the right corner of your screen to call up your chat function. So now I would like to proceed with the opening remark. I would like to invite Dr. Tomoaki Tomaki, the Deputy Secretary General of FARO, to give his welcome remark. Please, Tomo.
Thank you. Hello, members and friends of FARO. Welcome to the 11th FARO webinar. This is Tomo Tamaki. I'm the Deputy Secretary General of FARO, and it's my honor to make this opening greeting to all of you. It's been more than 1 year since FARO had started its webinar series, and we are happy to be having this webinar at this time of TASRO scientific meeting on SBRT for oligometastases, which is one of the hot topics of radiation oncology today. I would like to thank our distinguished speaker, Dr. Shankar Siva, and also all the panelists who will be contributing to this webinar. We're also happy to have our corporate member Varian as a part of this webinar. At the start of this webinar, as a Deputy Secretary General of FARO, I would like to thank the continuous hard work of Education Training Committee for organizing FARO webinar as usual, and especially Dr. Acharya Teatiti and Dr. Sarin Kipanit, members of Education and Training Committee from TASRO, who has been preparing this webinar for FARO. And I also would like to thank TASRO for providing support to this preparation. As with all the other webinars, this webinar has been supported technically by IROS, Indonesian Radiation Oncology Society, and also IRORA, Indonesian Radiation Oncology Resident Association. They have provided us with fabulous work as usual, and we would like to thank them greatly. With that, I would like to conclude my greeting and thank you very much to everyone. And I hope that you will all enjoy this webinar by Dr. Shankar. Thank you.
Thank you, Tomo. And now it is my TASRO time. Our TASRO president, Dr. Cholakiat Korprasert, will give his opening speech. However, he's not able to attend the live event today, so he sent his pre-recorded video to welcome us all. Okay, so Aras team, whenever you're ready.
Good morning and good afternoon, everyone. On behalf of TASRO, a local organizing committee, I'm very happy to welcome you all to today's webinar on stereotactic body radiation therapy in oligometastases, which is an evolving topic that we continue to face in our daily practice. I would like to thank Dr. Shankar Siva from Peter MacCallum Cancer Center, who is the world authority in SBRT, for accepting to be the speaker. I am sure that what Dr. Siva is about to share will shed the light on this issue and will be helpful for our society. Also, I want to thank the FARO Educational Committee, as well as IROS and IRORA, for their tremendous effort to continuously provide our society with scientific updates and educational events. despite the pandemic and their busy schedule. Just to give you a brief overview of Tastro, we have about 150 radiation oncologists and 150 medical physicists in Thailand. We have over 40,000 new patients per year and almost 40 radiation centers. Our first proton therapy center has been in operation since August 2021. So we are a small yet expanding society. I hope that we will be able to hold an in-person meeting soon. I and Tastro members will be more than delighted to welcome you all to Thailand. สวัสดีครับ
All right, thank you, Dr. Sholakia, for your welcome message. To start our program, we are delighted to begin with the topic of SBRT and radiation development by variant in Asia, presented by Berwin Sim, Senior Manager, Government Affairs at Varian.
Thank you, Dr. Sareen. On behalf of Varian, I would like to thank FARO and Tastro for giving us the opportunity to present. And I welcome all the panelists as well as the participants. So I'll just share my screen for the video from Berwin.
Very good day to FARO and Tastro committee members, esteemed speakers, respected attendees, and fellow colleagues. I'm Berwin Sim, Head of Government Affairs for Varian in Southeast Asia, and I'm very happy to be here with you today. First of all, we want to thank you for supporting cancer patients during this COVID-19 pandemic. COVID-19 has impacted cancer care in many countries, and we want to support you as you support cancer patients. As healthcare professionals, you would be familiar with the cancer burden in Asia, with over 20 million prevalent cases estimated over the next 5 years. Asia has the highest cancer incident rate globally in 2020. It is a challenge for healthcare providers to meet the increasing patient burden. Half of low to middle income countries in Asia have 800 new cancer patients for every clinical oncologist in the country. Through Varian's Access to Care program, we want to align with the FARO vision to enhance clinical practice in the region. We want to support you to build up qualified staff to treat growing numbers of cancer patients. Varian runs short educational programs on how to use our equipment, but Access to Care provides a broad range of education services. Through Access to Care, we're helping to turn nurses into radiotherapists, physics graduates into medical physicists, and oncologists into radiation oncologists. We introduced Access to Care in Vietnam in 2015, when radiation therapy students from 3 leading cancer hospitals, from K Hospital in Hanoi, Da Nang Cancer Hospital, and the Ho Chi Minh City Oncology Hospital, they embarked on the trainer course, becoming trainers themselves, and then providing training to others at their centers. Subsequently, we conducted SBRT training courses on liver and head and neck cancers in Vietnam in collaboration with Pham Ngoc Thang University and Ho Chi Minh City Oncology Hospital. We also conducted a workshop on the planning and delivery of SRS treatments. We look forward to expanding our Access to Care programs around the region to support more clinical providers. During the COVID-19 pandemic, many clinicians face challenges in providing treatment on-site for cancer patients due to safe distancing measures. For example, clinicians may not always be able to perform treatment planning on-site, or oncologists may not be able to approve treatment plans on premises. We've worked with our clinical partners to provide remote treatment planning for patients. This allows clinicians to work in different locations while ensuring timely oversight of all patients simultaneously. It also ensures continuity of care for cancer patients during a pandemic. We have been happy to support this in many countries across the region, including Thailand, Vietnam, Hong Kong, Korea, and Singapore. We're also very delighted to work with you to build knowledge and awareness about RT with key stakeholders, including government and patient groups. In Japan this year, World Cancer Day was celebrated with a light-up ceremony at 16 sites nationwide, with local government support for each site. Varian secured the participation of Jastro's reimbursement director, who presented at a session on how cancer care can overcome the challenges of the pandemic. The audience included members of parliament, Ministry of Health officials, patient groups, and representatives of medical societies. And this was the only session in the event which had a representative from Japan's Ministry of Health on the panel. In Indonesia, we were honored to partner with PORI, the Indonesian Radiation Oncology Society, as well as an Indonesian patient group, the Indonesian Cancer Information and Support Center, to provide an information session for cancer patients about RT as a pillar of cancer care. We were also very honored to have a Director General at the Ministry of Health deliver the keynote address. Finally, we are very happy to support National Radiation Oncology Associations as you build up national cancer statistics. In Thailand, Thai Astro has been collecting cancer data from various hospitals. This is a very time-consuming and laborious process. We have been very happy to support Thai Astro to provide a platform to simplify the process in collating cancer statistics and also to standardize the statistical data into a report. We want to thank you for your trust in us, your collaboration with us across the region, and we look forward to continued and new partnerships with FARO and the National Radiation Oncology Associations to increase access to quality care in Asia. Thank you.
Global cancer burden is rising, and more than half will have no access to care. That's not how we see the world. We believe that life cannot stop for cancer. That's why we're connecting technology, processes, and people to achieve our vision of a world without fear of cancer. And we'll get there through intelligent cancer care, through more personalized treatment, more data-driven decision-making, more direct access to care, and a new, more unifying, smarter standard of oncology. We have been pioneering advances in external beam radiation, proton therapy, brachytherapy, interventional oncology. For more than 70 years globally, and more than 40 years in Asia Pacific, from advanced data analytics to integrated knowledge-based software to intelligent treatment delivery. We've been fighting alongside the world's leading cancer teams, applying ingenuity to create an ecosystem that adapts. We are advancing people-centric best practices. And we never stop. This is for passionate game changers, for everyone committed to elevating the continuum of care, so people around the world don't have to fear cancer. People powering victories. Imagine a world free from the fear of cancer. We do.
All right, thank you, Varian and Bervin, and of course, Dr. Vishal, for an interesting presentation from Varian. And now it is my privilege to introduce our speaker, Associate Professor Shankar Siva from Peter MacCallum Cancer Centre, Melbourne, Australia. He completed his PhD with the molecular radiation biology, modern laboratory, focusing on translational investigations in precision high-dose lung radiotherapy. He is currently the chair of Stereotactic body radiation therapy program at Peter Mac, and is currently the chair of Trans-Tasman Radiation Oncology Group, or TROG, in the fields of oligometastases, lung, spine, and kidney cancers. So I'd like to hand over to Dr. Sharkar, if you'd like to get started.
Thank you very much. I really appreciate the opportunity to present to you, and I really do thank both Thastro and FARO for the invitation to be with you today. So my talk is based on stereotactic body radiotherapy in oligometastatic disease with a focus on SABR, on SBRT. The idea of oligometastatic disease is actually a long-standing concept. And in fact, the very first lung resection for oligometastatic renal cell carcinoma was reported in 1939 by the surgeon Barney. This was the first literature publication of metastasectomy, and this patient underwent a short course of radiation, a single acro fraction, and then subsequently a pneumonectomy for a metastasis from the kidney to the lung. This patient died 23 years later without cancer at the time of the autopsy. So there are several theories for metastasis-directed therapy, and this can be at both surgical and radiation approaches. The three rationales are that metastasis-directed therapy might be able to have a potentially curative treatment, although we're becoming more and more aware that this type of approach is more likely to be disease prolonging rather than curative. The concept that debulking of disease may help the efficacy of systemic therapy, and this is the Norton-Simon hypothesis, which is based on Gompertzian growth kinetics, which suggests that the best efficacy for systemic therapy, particularly cytotoxic therapy, is when there's microscopic disease. And finally, it's a concept of preventing metastasis to metastasis seeding of the disease, and this is a newer concept. So where does this concept come from for metastasis to metastasis seeding? Well, one of the areas that it comes from is from the Swanton Laboratory in the UK, which have done significant amounts of work tracking the evolution of non-small cell lung cancer. This group has shown that even within a single primary non-small cell lung cancer, there are multiple regions of completely separate clonogenic populations that are having private mutations that are not shared by subregions immediately adjacent to them. These private mutations and branch mutations are different between these particular regions, and it may be that these different subregions within the primary itself can give rise to different metastatic clones in sites of disease. Moving from that, we're also understanding that metastasis may also be an evolutionary process. Typically, we've expected that metastasis is a single event where the primary becomes one single shower of metastatic disease. And that's on that right-hand side, that orange dots in this particular schematic. Now, that may not be the case because with whole genomic sequencing and understanding of potential evolutionary processes, it may be that there's several other mechanisms. And this includes that the primary tumor may have parallel evolution and parallel polyphytic seeding to other sites of disease. There may also be cross-metastatic seeding from one site of metastatic disease to another, and from the metastasis back to the primary, so self-seeding. And on the top, there's also the concept of monoclonal seeding from the lymph node, the regional lymph node, giving rise to metastatic disease. There is some emerging evidence from this, from studies that have looked at whole genome sequencing in a rapid autopsy series. So this particular paper from Nature was looking at a rapid autopsy series in 3 particular patients, of which had established metastatic prostate cancer. These investigators were able to demonstrate that there was private mutations that were not shared within other regions, but shared between areas such as the primary to the lymph nodes on the left, in the middle panel on the in green, from regional lymph nodes with unique genetic information that was shared to other sites of metastatic disease and also other lymph nodes. And even further, more complex patterns of metastasis to metastasis seeding, metastasis to lymph node seeding, and metastasis back to the primary. There's clearly a very complex pattern of metastasis and seeding of disease from one site to another. It's in this context that the theory for local therapy has arisen. So in this schematic, this is an example of a patient that has a primary colorectal cancer. And initially, there's a low tumor burden that eventually grows to the point where the primary can become detectable. In this schematic, the very first event is M1A, which is liver metastases. And these are a single site of M1A disease, which is the blue dot in the liver, which then subsequently give rise to other sites of a disease also within the liver. The primary then gives rise to disease in the humerus, so N2A, which is the blue humeral metastasis. And then that metastasis gives rise to a further humerus bone metastasis, N2B. And then the humerus may give rise to the brain metastasis until the final terminal event is a polymetastatic seeding from the original liver cancer, liver metastasis, to multiple pulmonary metastases. So this kind of schematic gives the idea that one metastasis can evolve to seed other metastases in a rapid succession with little intervening evolutionary time. And it may be that terminal event of polymetastatic seeding may not be necessarily at the very first beginning point of the patient journey from the primary to polymetastatic disease, but rather on an evolutionary pattern from the development of a single site of metastatic disease. It's in this context that by using local ablative therapy, we may be able to reduce the risk of these further sites of metastasis to metastasis seeding. And at the moment, we don't actually know whether the best approach is either using the scalpel or more topically for us, about using stereotactic radiotherapy. I draw the audience to the attention of this recent paper in Lancet Oncology from last year, which gives an overall definition of the rather complex landscape of potential oligometastatic presentations. For my own purposes, I tend to think of it in a more simplistic manner, which is three particular patterns. One is a de novo or upfront metastatic setting. And this is the idea of either synchronous oligometastatic disease or metachronous oligometastatic disease, where the primary has presented and then subsequently a recurrence with low volume metastatic disease. And that's the upfront approach or de novo approach. A second pattern is what's called induced oligoprogression. And this is a context of a patient having initially had a polymetastatic disease or multiple sites of disease, then undergoes an effective systemic therapy and either has a diagnosis of a new growing lesion of a new site of disease, which is the blue dot, versus recrudescence of disease that has been previously controlled by systemic therapy, such as the red dot. And the final pattern is oligopersistent disease. And in this context, a patient has multiple sites of disease, has an active systemic therapy, and then may have a limited sites of one or two disease left to treat with local ablative therapy. So let's consider the upfront synchronous and metachronous oligometastatic disease concept. Perhaps the best evidence we have for this is the Saber Comet study. And this is a randomized phase 2 trial that had included patients with up to 5 sites of metastatic disease from any primary tumor site. And when patients would randomize either 1:2 ratio to either standard of care or standard of care systemic therapy with the inclusion of Saber local therapy. The progression-free survival data was published in Lancet in 2019, and this showed a significant benefit in those patients who received the intervention of Saber as compared to standard of care systemic therapy alone. And at the long term, this resulted in some long-term durable progression-free survival. This was a doubling in the median progression-free survival from 6 months to 12 months in the experimental arm compared to the conventional arm. This also translated to an overall survival benefit. And this had a p-value of 0.09 with a screening phase 2 study. This is positive, but nevertheless, the overall survival in the longer term resulted in a median overall survival of 41 months in those arms receiving conventional therapy, systemic therapy plus Saber versus the control arm of only 28 months. This group is further testing the boundaries from beyond 1 to 5 sites of disease. The Saber Comet study had predominantly a single site of oligometastasis reported. They're now looking at, this group is now looking at a study that's looking at patients with 4 to 10 sites of oligometastatic disease, termed Comet 10. And the idea is, again, a 1-to-2 randomization between standard of care systemic therapy versus standard of care systemic therapy and SABR to all sites of disease. This study is currently recruiting with a sample size of 159. Even more ambitious is a phase 1A trial called ARREST. And this is an example of looking to treat patients with up to 50 sites of metastatic disease, really pushing the boundaries. This is a planning study publication just released earlier this year that was looking at the treatment of up to 50 sites of disease in a single patient. And the complexity of the treatment plan in this case is very, very significant. From an Australian and New Zealand perspective, I can reflect on some data from the Trans-Tasman Radiation Oncology Group, a SAFFRON-2 clinical trial, specifically looking at the treatment of SABR for pulmonary oligometastases. This is the TROG 1301 badge trial. As a background to this particular trial, there is no randomized trial of the use of SABR for patients with pulmonary oligometastases, despite it being one of the most common sites of oligometastatic disease from any histology. This particular trial looked at randomizing 1-to-1 of single fraction SABR versus multi-fraction SABR, with the hypothesis that each arm would be acceptable from an adverse events profile, an efficacy profile, and also quality of life, but that single fraction SABR will be more cost effective. The safety endpoint was presented at the ASTRO plenary session in 2021 and did not change at the time of the subsequent publication of the final results. And this was that from a safety perspective, both of these arms, both multi-fraction and single fraction SABR, had an acceptable toxicity profile at 1 year, within 1 year of treatment. And this was 5% in the multi-fraction arm of grade 3 or higher adverse events versus 3% in the single fraction arm of grade 3 or higher adverse events. This was a pick the winner design of which all of the secondary endpoints were assessed and looking at patient-reported outcomes, including symptom severity and interference using the Radiasi lung cancer criteria, health-related quality of life using the EQ5D visual analog scale, and freedom from local failure, overall survival, disease-free survival, and resource utilization. The methods of the study: this is a multi-center, open-label clinical trial of which patients with 1 to 3 sites of oligometastases of less than 5 centimeters in size for each tumor from any solid organ malignancy was eligible. Patients needed to have non-central disease, so tumors located at least 2 centimeters from the central airway, have a good performance status between 0 and 1, and all primary and extrathoracic disease controlled with local therapy. This study recruited 90 patients between 2015 and 2018 across 13 sites in Australia and New Zealand, with 133 metastases treated in total. The randomization was balanced by the number of metastases and also the tumor histology. The multi-fraction arm was 4 by 12 gray, given over 2 weeks, a total dose of 48 gray. And the single fraction arm was a single fraction of 28 gray. The median follow-up for this population was 3 years. And the stratification factor was colorectal cancer versus non-colorectal cancer, and total number of metastases 1, 2 versus 3. The headline efficacy results: there was no significant difference between single fraction or multi-fraction SABR for overall survival, failure-free survival, or disease-free survival. So the overall survival is panel A in the top left in the Kaplan-Meier graphs, showing a hazard ratio of 1.15 favoring the single fraction arm that was not statistically significant. From a freedom from local failure, which is the top right panel in the Kaplan-Meier graphs, there was a hazard ratio of 0.5, not statistically significant, favoring the multi-fraction arm. And the disease-free survival and modified disease-free survival were really overlapping. That's the bottom left and bottom right panels. We looked at modified disease-free survival to describe the population of patients that were being salvaged after a subsequent progression with the use of local therapy, whether that be SABR, thermal ablation, or surgery. In other words, those patients that did not progress and receive systemic therapy. And in both arms, the modified disease-free survival at 3 years was roughly 40%. So a pretty substantial minority of patients having repeated SABR and not receiving systemic therapy at 3 years. With this strategy, from a patient-reported outcomes perspective in the overall population, there was really no difference in quality of life for each of the scales tested, and no difference between both of the arms, either comparing to baseline or comparing between the arms. We also did look at the cost utilization, and this is where the arms were different. So multi-fraction SABR cost $1,121 Australian, 30% more than single fraction. And of course, this is relative to the own currency, but just roughly 30% more than the single fraction SABR arm. Importantly, when we looked at the incremental cost effectiveness ratio, this did favor single fraction SABR with a difference of $2,700 Australian over the trial period. But the predominant cost for the patient was post-progression systemic therapy. And this is almost 10 times the cost of the actual SABR itself, indicating the cost effectiveness of this approach. One open question is whether which of these arms would be better from an immunogenicity perspective, as we do think that both fractionation may have an impact in the context of future immune therapy combinations. So in a subset of 18 patients from the Perhimpunan Cancer Center, we performed serial blood analysis, looking at CBA for cytokine analysis, CyTOF for a multiparametric flow cytometry analysis, and FACS. And we found that there was significantly elevated abundance of percentage CD4 positive, FOXP3 positive T regulatory cell subsets, and also checkpoint expressing CD4 positive, CD8 positive, and or combination CD4, CD8 negative T cell subsets. Comparing between the arms, there was statistically significant but clinically modest difference between the population of CD4 positive T cells and CD8 positive T cells, which the effector population expressing either of the checkpoints. And across all the populations, except for CD4 positive TEMRA cells, single fraction SABR had a significantly high percentage change in the subsets as compared to the multi-fraction arm. We did an analysis looking at responders and progressors. We defined responders as patients that did not progress within the landmark analysis time point of 1 year post-therapy. And relative to baseline, those patients that responded to SABR had a decrease in checkpoint expression of T regulatory cells and a decrease in abundance of checkpoint CTLA expressing CD4 positive effector memory T cells. Responders also had increase in cluster abundance of activated interferon gamma delta CD4 positive T cells, TNF alpha natural killer cells, TNF alpha CD8 positive T cells, and PD-L1 positive CD8 T cells, all indicating functional polarization of these effector cells and cytotoxic cells in those patients that had responded. This is an exploratory analysis and I guess gives us an idea of potential biomarkers in the future. So from that perspective, the optimal SABR fractionation schedule for immunogenicity is controversial, but our exploratory observation in the SAFFRON-2 study indicated that SABR alone induces changes in the composition of circulating immune cells and potentially alters their functional status, which is in itself remarkable because we're treating quite small volumes of disease relative to the human body. We concluded that SABR alone, both single fraction and multi-fraction SABR to pulmonary oligometastasis, drives systemic immune activation. And we hypothesized that this could be augmented with the addition of immune checkpoint blockade inhibitors in the modern context of cancer therapy. So as an overall conclusion to the trial, TROG 1301 found that both single fraction and multi-fraction SABR met the primary endpoint of safety, which is adverse event or severe adverse event profile of 5% of the multi-fraction arm and 3% of the single fraction arm. There's no significant differences in patient-reported outcomes, efficacy, survival, and both arms were able to induce a systemic immune activation. But single fraction SABR was picked as the winner based on a favorable cost-effectiveness profile. And these findings are consistent with randomized phase 2 trials in primary non-small cell lung cancer, including the RTOG-0915 study comparing single 34 gray versus 48 gray 4 fractions, and the Roswell Park 30 grain 1 fraction versus 60 grain 3 fraction study. In all 3 of these randomized trials, single fraction was chosen to escalate into future trials as a preferred arm. Also, it's also the first study that's been fully recruited in patients with pulmonary oligometastases. There has been one other study in a surgical context, comparing surgical metastacectomy to observation for pulmonary metastases from colorectal cancer. This study recruited 65 patients and terminated early, and control rates of progression were not reported. But when looking at surgery, the 4-year overall survival in the PUMIC study was 40% in the control arm and 43% for surgery. And in SAFFRON 2, we observed a 4-year overall survival in the multifraction arm of 58% and the single fraction arm of 81%. So this really does look at when we have radiation, which had no detriment in quality of life, whereas surgery had an initial and expected drop in quality of life at 3 months without longer term detriment. There is really an equipoise here for a randomized trial in this context of SABR versus surgery for pulmonary oligometastases. The audience would like to refer to this data. This is now published in JAMA Oncology a couple of months ago. From a Peter Mac perspective, we've also recently reported in 2021 some of the outcomes in safety, efficacy, and patterns of failure after single fraction SABR for generalized oligometastasis. This was a retrospective report at our institution looking at 371 patients treated with 494 extracranial metastases, a mixed population of between 1 and 5 metastatic sites of disease. We had a median follow-up in this analysis of 3.1 years, quite reasonable for an oligometastatic population. From a safety perspective, there was a pretty low level of high-grade adverse events, consistent with what we saw in SAFFRON 2 in the prospective setting at 3%, with no grade 5 toxicities. The median overall survival from the Peter Mac population was 5.4 years, and the median progression-free survival was considerably smaller at 1.0 years. But we also looked at the same kind of concept, what we termed widespread failure-free survival, what we analysed in SAFFRON 2 as modified disease-free survival, as capturing those patients who had subsequent salvage therapies without requiring systemic therapy. So the repeated approach where patients who had relapsed in an oligometastatic pattern and received further local therapy. And that population at 3 years had a widespread failure-free survival of 39% and at 5 years of 24%, quite a healthy tail in that group. This translated into freedom from systemic therapy in our population at 3 years at 43% and at 5 years at 35%. Interestingly, from our patterns of failure analysis, there's 2 cumulative incidence graphs. We saw that the predominant pattern of failure was a red line at distant failures, and that's quite expected. But when we look at the next most common pattern of failure, which is the green and purple lines of cumulative incidence of failure, the second most common patterns of failure was local regional to the primary. And this may indicate that we may need to consider using maximizing the local control and regional control of the primary disease when embarking on radical treatment of oligometastases to be able to prevent future failures. So the conclusions from our own Peter Mac experience is that single fraction SABR is highly tolerable with less than 3% high-grade toxicity rate, and 43% of patients were free from systemic therapy at 3 years and 35% at 5 years. And this may be an important strategy to maintain quality of life. There may also be a subset of quotation marks cure at 5 years at 14% to somewhere between 24% with repeat SABR, and this is hypothesis generating. So let's consider an example case. This is a 62-year-old gentleman who's fit and well and a full-time manual labourer who presented with a high-grade, large 85mm clear cell carcinoma of the left kidney, which was resected in January 2015. This patient also had a synchronous right lung metastasis resected at the same time. A short while later, within the same year, this patient represented with 2 further lung metastases in 2015. He consented to receiving SABR to these 2 sites, and he received 2 single fraction 28 gray treatments to these 2 sites on the SAFFRON 2 trial. He had 2 further lung metastases, in 2015, which we treated, but in April 2016, he had subtle increased uptake in a bulky left adrenal metastasis. So this patient had this extra adrenal metastasis, and the question is, should we pursue this local ablative approach or switch to systemic therapy? Just an interesting point, a subnote, I won't spend too much time on this, but this lesion was not so avid on a PSMA, on an FDG avid lesion. It was mildly metabolically active, but renal cell carcinoma can be quite avid on PSMA as well. And this is because it lights up the neovasculature. So this is 3 different panels that before the lung saver, there was no evidence of disease in the left adrenal gland on PSMA. This is after the lung saver, a handful of months later, there was a disease of 40 millimeters, intensely PSMA avid. And shortly after the saver was delivered, had a complete PSMA response on that left adrenal metastasis. But 6 months after adrenal saver, this patient presented with 2 new sites of disease, a new lung metastasis, in the right lower lobe. So that was November 2016, and this patient proceeded to further right lung saver. If you look at the timeline of this patient, after that right lung saver, had 2 further sites of lung disease and then a site of metastatic disease to the spine that all received saver. And in this patient's journey from January 2015 to July 2008, he underwent metastasis-directed therapy to 6 different sites of disease, saber times 5 and metastasectomy times 1. And this systemic therapy was delayed by 3 years. And this may be a significant benefit to the patient rather than having the ongoing detriment to quality of life that a TKI like sunitinib may impact. So let's switch track to local consolidation saber as a treatment strategy. You may recall this initial image where we're talking about upfront de novo treatment of oligometastatic disease, either synchronous or metachronous. And let's switch track to the oligopersistent disease, where there's a phase of induction systemic therapy and then local ablation of the remaining sites. This is a schematic of what can be predicted. So the patient initially presents with polymetastatic sites of disease in the middle, with multiple sites of untreated primary and metastatic disease. And after systemic therapy, there's 1 or 2 outcomes. One is that there's either on the left, widespread persistent disease, or on the right, more likely, some sites of residual disease. Few patients undergo or have a complete response to current systemic therapy lines. But there may be some persistent disease after this induction treatment. Again, the best data that we have in this context is randomized phase 2 trials. This particular study was a randomized phase 2 trial run at London, Ontario, at Colorado and MD Anderson, which was looking at patients who presented with 1 to 3 sites of oligometastatic non-small cell lung cancer who initially underwent induction systemic therapy and then were randomized to either continuous maintenance therapy or the use of local ablative therapies or metastasis therapies after 12 weeks of systemic therapy. This trial was remarkable in the sense that the Data Safety Monitoring Committee halted the trial after 49 patients had been recruited. And this is on futility of the primary endpoint. And this is because the standard of care, the maintenance therapy arm, was thought to be futile. And this is quite extraordinary because this is saying that in a trial setting, the Data Safety Monitoring Committee thought that the standard of care for stage 4 non-small cell lung cancer was not ethically acceptable to be proceeded to on this trial. So in this context, also important to know that the local consolidation arm after induction systemic therapy improved progression-free survival, but it wasn't just stereotactic radiotherapy that was used. This certainly was a predominant use of treatment, but there was a smattering of both chemoradiation therapy, combination stereotactic radiation and chemoradiation therapy, and surgery and radiation treatments. Surgery alone was a minority at 4% of use as metastasis-directed therapy. This study was published in the JCO in 2019, and again was treatment of 3 or fewer sites of metastatic disease after 4 cycles of first-line therapy. And the investigators found that there was a tripling of the median progression-free survival from 4.4 months in the standard of care arm as compared to 14.2 months in the local consolidation therapy arm. And the investigators hypothesized that this might be because the patients that received local consolidation treatment had a longer time to a new lesion developing. So this was 14.2 months to a new site of metastatic disease versus 6 months in the standard maintenance arm. So this has shown that perhaps the main reason for this is not because of progression only in the sites of initially detected disease, but metastasis-directed therapy may reduce the risk of future metastases developing. This did translate to a statistically significant overall survival benefit in the experimental arm, and this is quite a healthy difference at the median overall survival of 41.2 months as compared to 17.0 months. And this is despite almost half of the patients in the maintenance therapy only arm receiving local consolidation at progression, again indicating that it's that early intervention of the SABR in this context that potentially drove the outcome rather than receipt of local consolidation at progression. Now, this kind of remarkable difference, if this was a industry drug, a pharma oncology drug, this would be the next blockbuster. But really, this does show that radiation can have these kind of significant effects in well-selected patients. This study was also replicated in a contemporary publication from UTS Southwestern in Texas, which also failed to recruit its entire population, but had 34 patients and 29 in total randomized to either maintenance therapy alone versus maintenance therapy plus SABR to residual sites of disease. This particular approach is currently being investigated in the NRG LU002 study. This is a large international study that's looking at randomizing patients with a similar design to the previous 2 studies. So again, non-small cell lung cancer with up to 3 sites of oligometastatic disease, all of which are amenable to local therapy. And these patients receive 4 cycles of first-line induction systemic therapy, and the protocol had been modified to include systemic immunotherapy. The arm 1 is just maintenance therapy alone, and arm 2 is any local consolidation therapy, be it stereotactic radiation or surgery, to all sites of metastasis and radiotherapy to the primary. I direct the audience to this literature review that our group just has produced in translational lung cancer research, which kind of identifies those 2 different populations, either the upfront or outback type of approach for local consolidation. When you specifically look at that outback approach using local consolidation therapy after initial systemic therapy, there are quite a few studies that are looking at this induction therapy approach. These studies randomized phase 2 and phase 3, and also single arm phase 2 studies. And in total are looking to recruit close to 1,000 patients. So in the next few years, we'll have high level evidence to be able to support the use of SABR in induced persistent disease. The final type of simplification of this oligometastatic paradigm for me is the use of oligoprogression. And this is the context, again, just to recap, patients who receive active systemic therapy and most of their sites of disease are controlled, but then they have progression at either existing sites of disease or new sites of disease that were not previously detected. I'd like to highlight one of the higher level data that we do have, that this literature in this space is very scarce and there's not much to look at from a prospective perspective. But this study from Sunnybrook was recently published in European Urology. This study, again, failed to recruit its recruitment target, was able to have 37 patients in total who had oligoprogression on a TKI and looked at SABR to 1 to 5 sites of disease in a single-arm phase 2 approach. The 1-year local control from this population of renal cell carcinoma was 93%, which is exceptional. And the median progression-free survival was 9.3 months, which your authors argued was much higher than that would be of switching systemic therapy from historical controls. The median time in this cohort that was switching from systemic therapy was prolonged, so a further 12 months prior to requiring switching systemic therapy, despite having progression on that first line of systemic therapy. And there were no grade 3 to 5 toxicities noted. These authors did pause the systemic therapy during the delivery of the stereotactic radiation. Most of the data in non-small cell lung cancer, which is probably a bit further advanced in the field, but still has not got prospective trials, were initially enthused by some data from Colorado that was looking at patients retrospectively who had crizotinib alone versus crizotinib plus SABR in those patients who were initially progressing after initial ALK-positive driver mutation non-small cell lung cancer TKIs. They found that the use of maintenance or ongoing crizotinib resulted in 2-year overall survival of 12% versus the addition of stereotactic radiation having a 2-year overall survival of 72%. There are currently 2 randomized controlled clinical trials running in 2 continents that are looking to address this question. And surprisingly, they both have very similar names. One is the STOP trial from Canada, and one is the HALT trial from the UK, which led to quite a funny tweet from Professor David Palmer saying that we're offering all HALT candidates free airfare to Canada to be able to help recruit there. The STOP study, and this is the study from Canada, is looking at patients with up to 5 oligoprogressive lesions who are progressing on systemic therapy and plan to switch to a new systemic agent. And they're randomized either 1 to 2 to either standard of care, which is a switch to a new agent, versus arm 2, which is continue the same therapy, but addition of SABR to up to 5 sites of disease. The HALT study, which is the UK study, has patients with EGFR driver mutations or ALK driver mutations in non-small cell lung cancer who initially respond to TKI but then subsequently progress. And they need to have up to 3 sites of extracranial progression. And they're randomized 2 to 1, either SABR and continue the TKI or just continue the TKI, which is a slightly different spin to the STOP study. So just as an example case, we have a patient who has a 52-year-old male who's a non-smoker, ECOG 0, and had a left lung mass, pleural and pulmonary nodules, had a EGFR exon 19 driver mutation, and received Tarceva or erlotinib as a first-line therapy. 8 months post-diagnosis, he had a very good response to treatment, but then developed one area of oligoprogression in a site of a solitary rib metastasis. And that's an FDG PET showing solitary site of progression. This patient had a single fraction of 24 gray to this site in the left 9th rib, which is lytic and eroding the bone, and tolerated this treatment well. At the 14-month time point, that's some 6 months after that rib SABR, this patient had no further rib pain, but then had some sites of disease on CT that were confirmed on a PET scan that showed increasing size and activity of 2 adjacent lung lesions that were central, but not ultracentral. Because of these 2 adjacent lung lesions were quite close, we delivered a single fraction of 18 gray to the site. This is a demonstration of ultracentral areas, which is within the proximity of the trachea and primary bronchial airways. This was slightly out of that in the secondary airways, so we use a central approach. 24 months post-treatment, this patient had 3 small pleural lesions, pre-aortic lymph node and 11th rib metastasis, some multi-organ progressive disease. So at the 24-month time point, even though initially progressed at 8 months, this is the time that the patient received a switch in systemic therapy. The best response, however, was partial, and they rebiopsied the lung mass, and this showed a T790M driver mutation on exon 19, and this patient was commenced on a clinical trial at that time point and received ruxolitinib. At 47 months post-diagnosis, the CT showed stable disease, but a left rib met that was increasing in size, and this is the 11th rib, and multiple sites of pleural disease. The patient ceased ruxolitinib due to a cataract and side effect and toxicities, as well as the sites of progression, and was commenced on osimertinib, which is a third-generation EGFR agent. Because of symptomatic pain in this 11th rib, the patient also received a further site of SABR to the 11th rib of 24 gray in a single fraction. 57 months after diagnosis and 10 months after commencing osimertinib, the patient had increasing size in the previously irradiated left highland. That dose of 18 gram 1 is quite gentle, and this did result in a local progression in the site. And this patient subsequently had external beam radiotherapy with 30 gray and 10 fractions as a reirradiation approach. 63 months later, this disease in the left highland was stable, but elsewhere had progressed, and again with pain in the right hip. And this was a right iliac lytic lesion and a solitary 6 mm cerebral lesion. So we had two issues here: managing the painful left hip, the right hip, sorry, and the painful and the new solitary brain metastasis. This patient underwent a pretty passive approach, which is a simple field, conventional 8 gray and 1 fraction to the right hip, and then SRS to the brain with a 20 gray and 1 fraction to that site. And osimertinib was ceased, and the patient commenced systemic chemotherapy. The single 8 gray fraction conformal therapy was pretty much immediately regretted because the patient had emerging right hip pain 4 months after that treatment. The CT showed that there was increasing site of lytic metastasis, and at this time we decided to reirradiate this again with a single fraction to try to improve local control and pain relief. And this was successful, but at 74 months post the diagnosis of metastatic disease, this patient had PET generalized progression and started on an IMpower 150 regimen with atezolizumab, bevacizumab, and chemotherapy. So quite a remarkable journey of which radiation played a very big role in this patient's disease course. So in summary, I'd like to conclude by saying that SABR for oligometastatic lung cancer and just disease in general can be used in one of three settings. One is the presentation of de novo or metachronous oligometastatic disease. That's that upfront approach where we try to give the best local therapy to achieve longest control and durable control of disease, potentially even cure in a very minor subset. The second approach is local consolidation after successful systemic therapy. And this is the idea that during the course of systemic therapy, not at the end, but within the first few cycles of induction treatment, we use SABR to consolidate persistent sites of disease. And the third one, which has probably the least amount of prospective evidence, but it's an area of interest, is the site of oligoprogression. And in this context, it's the idea that there are some clonogenic burdens of metastatic disease becoming resistant to the systemic therapy, which is otherwise effective. And we use SABR in this context to prolong the use of the systemic therapy. The summary is the approach is safe and effective, and we have ongoing clinical trials investigating the impact of survival. And so with that, I'd like to thank you all for your attention. And again, thank you again for the invitation, the opportunity to be with you today. Thanks.
Thank you, Dr. Shankar, for an excellent talk. So now it's time for questions. I think everyone can reach to their Q&A, and that would be a couple of questions that people has been posting here. So I probably might start with the first one at the top of the box. So one attendees is asking, is there a minimum dose threshold for inducing immunogenicity when doing SABR for oligometastasis disease?
This is a really excellent question. There are two things to unpack in that particular question. One is, what is the best dose for immunogenicity with radiation, and what is the best approach for oligometastatic disease? I think they're two different things. We're not exactly sure what the best dose is for inducing immunogenicity. Some investigators are looking at low doses, so even minimal doses, less than 2 gray bystander lesions to help induce immunogenicity. There are other groups that are looking at a moderately hyperfractionated approach, so maybe 8 gray by 3, for example. We're looking at more ablative doses of radiation in the context of oligometastatic disease. We're not certain that the data is conflicting in this space, and more work needs to be done. In the context of oligometastasis, though, I think it's quite important that you do try to treat to ablate the disease, because these patients have limited sites of disease, and the priority should not be inducing immunogenicity. That's a helpful side effect, but really we should be controlling the disease that we can see to make sure that we have prophylaxis for future symptom control, but also potential for durability of disease control.
Well, thank you for your answer. So I would probably go to the next questions. How do you calculate the organ at-risk constraints if there is any overlapping field between each saber?
I'm going to assume that this is upfront, so basically multiple sites of disease at the same time. So generally speaking, the technical approach that I take and our group takes is that we would make sure that we achieve coverage of each oligometastasis to the ablated dose, or whatever preferred coverage that is. Our typical approach at Peter Mac is allowing D99% of the PTV to receive the prescription dose. So we do that for each individual lesion. Then we summate the overlapping doses for the sum plans for each of the individual organ at risk. Typically, the major issue is actually the peak doses, so the small volumes that are receiving high dose, and they don't tend to overlap, because often if they are that close to be that kind of situation, we would use a single isocenter to encompass both in the same treatment plan.
I see. Okay, I might proceed to the next questions. They said that there's a report from Jillian from Memorial Sloan Kettering Cancer Center. She reported in ASTRO 2021 that saber to oligoprogressions benefit for lung cancer rather than breast cancer. They're asking if there's any reason that can be explained why the ablative dose and the same mechanism of action is in killing cancer cells or immunomodulations, or is there any difference in terms of outcomes?
This is an excellent question. And so, that was a really interesting talk. Our own group is actually doing a similar, a specific trial called Avatar, which is a TROG study that's looking at oligoprogression in the same kind of setting for breast cancer. And we're finding, there might be something to that. Maybe breast cancer with the hormone positive type of groups may not be the best groups to be targeting with radiation. So this data is still being presented. Will be presented at the San Antonio breast cancer meeting by my colleague, Dr. Stephen David. The issue is, though, that probably there's multiple factors. There's not only the tumor histology, it's also going to be the tumor niche, so which organ that we're treating with the radiation. So there are some areas such as the liver that may not be as potentially immunogenic as other sites, such as the lung, and definitely the bone may not be the best site to be treating for this type of immune combination. So we have tumor histology, tumor niche, radiation dose, radiation sequencing as well, which is another issue with using systemic therapy. So there's lots of complicating factors that would need to be explored. I think the breast cancer story is an emerging one, and it's really interesting. We're going to need to look at that in the future, if there is a difference between breast cancer specifically and other types of cancers.
Right. I hope that a person that is asking get an answer. And then now there's a couple of questions about the dose. I am receiving the questions from FARO side and also from the Tastro side. They're asking, what is your recommendation for SABR dose for the central and ultra central lung metastasis?
So that's a really good question as well. Typically speaking, we use a different approach for non-small cell lung cancer than we do for lung metastases. So in general, for ultracentral lung metastasis, we don't treat those because the risk-benefit ratio is too high. These patients already have established metastatic disease, and trying to treat an area that's potentially toxic, which is ultracentral lung, it's just not worth the risk-benefit ratio in my mind. For central lesions, so within 2 centimeters of the proximal bronchial tree, we do follow our non-small cell lung cancer approach. So we're typically using 50 gray in 5 fractions in this context, using the RTOG 0813 type approach. Or more commonly, which we still try and do as our preference, is to try to use a technique such as deep ventilation breath hold and use single fraction 28 gray.
Oh, okay. Does this apply to a tumor that is close to the great vessels or the mediastinum?
So yeah, that's also a complex question. The mediastinum we don't necessarily consider as a central structure, so it depends where it is. So we don't use a 1 centimeter zone around the mediastinum, which some centers do, some particular ISLC recommendation. We would only apply that to the airways. And definitely the aorta, for example, is a very robust organ and very happy to give full dose ablation around the aorta.
All right. Well, I think I'm being flooded with a lot of questions. I will just try to, get Dr. Shankar to answer all of this if you have time. Okay, so come to the next questions. Do you think SABR is safer and more effective with MR Linac?
No. Short answer is no. I think it has a very important role around the abdomen, so the abdominal areas, so liver, adrenal, lower lobe lung, kidney. These are all areas that can possibly benefit at the moment. The use in other areas is still needs to be found, I think.
All right. Okay, so another questions. I think you have already mentioned some of the answers about this. She asked, how do you consolidate your lung doses with repeated SABR to the lungs? Up to how many times can you repeat SABR to the lungs? So I think it depends on the dose, the summation of the doses, right?
Yeah, summation of the dose. We don't discount for organs at risk. So in other words, if we just sum the volumes of plans, and we use that application of the volume of the normal lung receiving 1,000 cc. So it's like the same way you do the volume of normal liver receiving SBRT. We prevent less than, say, for example, 1,000 cc less than 7 gray in a single fraction approach, or multi-fraction. I think it's 12.4 gray for 1,000 cc.
Yeah.
And for multiple SBRT, it's until we become uncomfortable, basically. So I think that's different in different people. Yeah, it's a comfort factor and how quickly these patients are representing.
Did you have any specific constraints for patients with interstitial lung diseases or COPD? Because I think they have sensitive lungs that can be, very fragile after SABR.
So COPD, not so much, because I think that's quite a common presentation for patients with primary non-small cell lung cancer. We use SABR all the time. But for interstitial lung disease, definitely there's a high risk population. So we try to look for alternative approaches, so surgery, potentially even radiofrequency ablation. And if we have to do it, then we counsel the patient of a high risk of toxicity.
Right. Okay, next questions. Are there any specific concerns about giving SABR during TKIs or immunotherapy?
Great questions. So there's prospective studies and retrospective studies from the TOAST group, which is a multi-center international registry. There seems to be some additive toxicity. So this is also intracranial and extracranial. Some additive toxicity with concurrent TKIs. It's not so much with the immunotherapies. It seems to be additive, just a little bit extra toxicity rather than excess toxicity. So for TKIs, it depends on our approach. If we're using single fraction stereotactic for oligometastases, we stop perhaps a day or two beforehand and start again a day or two afterwards. If we're using fractionated stereotactic radiotherapy, where it can take up to 2 weeks to deliver, we continue throughout the course of the treatment, just because the risk-benefit ratio for stopping the TKI for that time.
All right. Okay, we have like two more questions here. Oligomets or the spine, what is your preference dose for ablative or pain control of your preference dose, and the main outcomes that you're looking for?
So that's changed also this year with the publication of the SC24 trial, which is the Canadian Cancer Trials Group study, as well as TROG 1706. So we use 24 gray in 2 fractions as our preferred approach for spine in general. And the main outcome has now changed, that we are actually applying this for painful palliation of disease rather than just for oligometastatic disease. So now it's more of a common practice.
All right. We are starting to use the doses, the 2 fractionation doses as well. Okay. What is your view on Sunset trial? 60 gray times 8? No, sorry. 60 grays in 8 fractions on central lung trial by Toronto group.
Yeah, so that's a very interesting trial that still needs to read out, which is really important, going to give us a lot of information in the field. That's a non-small cell lung cancer study, and we already have data from the Nordic HILAS study that shows up to, I think, a 25% rate of high-grade hemorrhage with ultracentral lesions. So this study, and also there's also retrospective data from VUMC that also shows high rates of toxicity. So this study will hopefully give us some more safety data on this fractionation approach. I think that we have to be very careful with ultracentral lung. Central lung, I think it's probably reasonable to approach this, particularly for non-small cell lung cancer. For oligomets, we have to always weigh up the risk versus benefit ratio in patients who already have metastatic disease.
All right. So I think we have a couple of more minutes for the last question here. And I want to know this as well. The question is, what should be the minimum time gap after you can repeat this saber after a single high dose saber, like 28 gray?
Can I clarify, is that to the same lesion as in the lesion failure?
I think she means the same lesion after you have been giving a single. And yeah, I think that should be like a repeat.
So to use a different modality after one modality has failed. So for example, if there's a surgical wedge resection in the lung and then there's a marginal recurrence, best to approach that not with further surgery, but with stereotactic radiation. And for me, it's the same. If you have a lesion that's failed saber, this is obviously a resistant lesion, best to approach that with a surgical approach or perhaps the interventional oncology as an approach. Having failed that, and if there's not a role for those approaches, we have used a fractionated reirradiation approach. And again, this is a 50 gray and 5 standard approach for all of these reirradiations. They're uncommon, I must say, it's pretty uncommon. And the minimum time gap is a good question. I don't think anyone knows the answer to that. I think I'd be reluctant to redeliver saber within a year after the previous one, simply because it probably means the cancer is resistant to this treatment approach.
All right. All right, I think we have already answered most of the questions that's been posted in the Q&A. And I think we have learned a lot today from Professor Shankar. I want to thank you for sharing your time on Saturday with us. And I will see you in a minute in the other Zoom. So thanks all attendees for your participation. And I would like to probably end the webinar here. I hope you guys have a great weekend, and I see you in the next month's webinar hosted by Mostro. All right. Okay. Bye. See you. Thank you everyone for helping with the webinar today.
Great work, Dr. Saren.
Thank you, Tomo.
Thank you, Dr. Siva. Is he already gone?
So, yeah, I think he's already gone to another Zoom because he will be having another session with Tastro.
Okay.
Yeah.
Right. Great work. Thank you.
All right. Thank you, everyone. See you in a monthly meeting.
Thank you. Thank you.
Bye.
Bye.
Thank you, everyone. Bye.
Thank you, Mayang.
Thank you.
Bye, Tati. Bye, Anita.